So I'm Aravindhan Veerapandiyan, Dr. Veerapandiyan. I'm a pediatric neuromuscular neurologist at Arkansas Children's Hospital, University of Arkansas for Medical Sciences. Duchenne muscular dystrophy is an excellent neuromuscular disorder. It is a progressive neuromuscular disorder, usually affecting boys. They typically present around age 4 to 5 years with muscle weakness, difficulty walking, running, getting up from the floor, that kind of issues. Usually, it's a progressive disease, so it tends to progress throughout the life. Around age 10 to 11 years old, 11 years, they lose ambulation. And then since it's a muscle disease, in addition to skeletal muscle, it also affects heart muscle and breathing. So cardiomyopathy and respiratory weakness also comes into play when they are teenagers. So Duchenne muscular dystrophy is due to pathogenic variants or mutations in a gene called dystrophin gene. Dystrophin gene helps with making dystrophin protein, and dystrophin protein is essential for your muscle membrane stability and muscle contraction. So in these boys with Duchenne muscular dystrophy, there's absent dystrophin or non-functional dystrophin. So that affects their muscle stability and muscle contraction, causing muscle injury and inflammation, leading to this progressive muscle damage. Usually when you look at these boys, there is evidence of muscle damage by increased serum creatine kinase levels even at birth. So there is a delay in diagnosis. The typical presentation is 4 to 5 years with muscle weakness. But if you look at the evidence or the literature that's been published, there is a good paper from a group called MD-StarNet that included multiple sites within the US. They did a research many years ago looking at the delay in diagnosis. There was about 2 to 3 years delay in diagnosis from the symptom onset. And then they went back more recently to take a look at it again, because there was a lot of initiatives from American Academy of Pediatrics and other organizations to bring awareness and educate the primary care providers and other specialists to see if that would help with reducing the delay in diagnosis. When they went back and look at the data, there's that same amount of delay in diagnosis. We still see patients coming in at age 8, 9 years old as a new diagnosis Duchenne. And I think that's why the newborn screen effort's been going on. So that would help with early diagnosis. One, to highlight, you have to make sure that the primary care providers, if they see any patients with concern for developmental delay, developmental concerns in the clinic, one, instead of taking the wait and watch approach, be proactive and refer them for further evaluation. Check a CK level. If they're getting blood work for CBC or CMP, their basic labs, always check for CK. So that's one. Number two, a lot of these boys, not a lot, a good chunk of these boys with Duchenne can also have behavioral problems, problems or cognitive issues or problems similar to autism spectrum. Because dystrophin, there are some isoforms of dystrophin that's expressed in the brain also. So sometimes those behavioral problems can predate the onset of muscle weakness. So that's another recommendation. We can check CK levels if you see a patient, maybe a 1-year-old or 18 months old in the clinic that have concerns for behavioral problems or autism spectrum-like concerns. So yes, most of it is around serum creatine kinase levels, CK, which is a simple test. If you look at, we talk to our pediatricians, other primary care providers to check CK as part of the routine blood work that they're doing in the clinic, especially if you're seeing a boy with muscle weakness or developmental delay or other things. It's a simple test, and like I said before, the CK levels are actually high at birth. So when I say high, these boys typically have CK levels somewhere in 10,000s, 20,000s, like that. Normal CK is about, it varies depending on the lab. It's about 100, between 100 and 200 units. So the newborn screen is all the focus is mainly on the assays to check for CK level and then actually come up with a cutoff for the CK levels and see if the creatine kinase is high. Then you will proceed with the next step of testing, genetic testing. So right now, as you would know, New York and Ohio are getting ready to implement the newborn screen for Duchenne. So the gene transfer therapy has been a treatment modality targeting the genetic aspect of the disease. So it's typically it's given through intravenous infusion, and what happens is we need a vehicle to carry this gene or protein into our body. So most of the studies looking at the gene transfer therapy for Duchenne, they use a virus called adeno-associated virus, or AAV, as a vector. And AAV is being chosen because we know AAV vectors, they are non-pathogenic, meaning they don't cause any disease in humans. And they also have low immunogenicity, so the safety profile is it's favorable. So that's why most of the gene transfer therapy programs, almost all of them that we have right now, they use adeno-associated virus. And there's different serotypes from AAV8, AAV9. So different programs use different serotypes of AAV. Then you want to look at the actual the gene itself. As we all know, dystrophin gene is the largest gene in the body with 79 exons. And if you look at the size of the gene, it is about 14 kilobases. Whereas the virus that we are talking about can hold only up to 4 or 5 kilobases. So then the challenge is, how are we going to fit this big 14 kilobases gene into this vector that can take only up to 5 kilobases? So that's when we went back in the literature to look at some of the patients that were reported in the past who were ambulating at the age of 60 still. So they had milder Becker phenotype, and they were still walking around age 60. So then you looked at their genetic change. About 50% of their coding region and the gene was missing. So using that concept, researchers have developed what's called the micro or mini dystrophin. So it's a shorter form of dystrophin gene, keeping just more critical parts of the gene. So that kind of makes up to 4 kilobases, so it can actually fit within that vector. There are different constructs being used in different gene therapy programs, again, all based on the concept of that milder Becker patient who are still ambulating at age 60. The key difference in the gene therapy construct for REGENXBIO, the RGX-202, is maintaining what's called a C-terminal domain, which is found in naturally occurring dystrophin. So that domain is preserved in the microdystrophin construct of RGX-202. So we looked at the interim clinical data that we have as of February 2024. So the key eligibility criteria for this phase 1/2 study is the boys have to be age 4 to 11 years old at screening with genetically confirmed Duchenne muscular dystrophy, and they should not be having any pre-existing antibodies to the AAV8, which is the vector that's being used in the study, in this gene therapy program. So there's 2 dose levels. There's dose level 1 and 2. The dose level 1 was 1E14 genome copies per kilogram. And then dose level 2 is the 2E14 genome copies per kilogram. So we have dosed 3 dose level 1 patients and then 2 dose level 2 patients. And we have data from those 5. If you look at the actual trial design itself, there is baseline assessment, and they get muscle biopsy at baseline. And then if you have the gene transfer therapy administration, and you look at muscle biopsy at week 12 after the infusion, and then they'll be followed for a year for safety and tolerability. And there are also some muscle strength assessments and cardiac MRA and skeletal muscle MRI assessments done throughout that period. And then there's a more comprehensive immunosuppressive regimen that's being used in this program that included corticosteroids, eculizumab, and sirolimus. Now, so far, among all the both high dose and low dose, or dose level 1 or dose level 2, so far the RGX-202 has been well tolerated with no serious adverse events. The follow-up post-administration period is somewhere between 1 month and 11 months, including all of those 5 patients. If you look at the microdystrophin expression data for dose level 1 patients, we have 3 patients at dose level 1. The first patient is 4 years at the time of dosing, had 38.8% of microdystrophin. And the second patient is was 10-year-old at the time of dosing and had 11.1% microdystrophin. And then our third patient was 6 years and 6 months at the time of dosing and had 83.4% microdystrophin. Just to remind, I think the microdystrophin expression is reported as percentage of normal control. And if you look at their CK levels, there's a remarkable reduction in the CK levels at week 10 after infusion compared to their baseline. For dose level 2, the first patient was 12 years actually at the time of dosing, was 11 years at the time of screening, but 12 years old at the time of dosing. The microdystrophin expression at 12 weeks was actually 75.7% of normal control, which is robust microdystrophin expression in this patient. So if you look at put it all together, RGX-202 had shown microdystrophin expression at both dose levels along multiple ages, from age 4 to 5, 6 to 7, and also age 11-year-old. So I think the goal is to give them some amount of dystrophin because the dystrophin protein is lacking. So that would make some impact on their function, so slowing down the progression of the disease. Now, do we think is this on these gene transfer therapies a cure? They're going to stop the progression of the disease, or are they going to reverse the disease process? Probably not. There's going to be slowdown of the progression of the disease. You may be able to keep them on their feet walking longer than what you normally do with other standard of care measures, including steroids. We may be able to slow down the progression from a cardiac standpoint or from the respiratory muscle standpoint, but we just need to collect long-term follow-up information on those.